a number of months ago, I wrote some things in the Lund report encouraging advocates to become more knowledgeable about the specific things that the issues that confront the Oregon Governance Board, and how how we as an advocate community can do a better job of supporting that. So the governance board gets 2.5 years to put together a plan. If this works, as I'm sure it will, we will, just by answering 18 simple questions, we will arrive at a plan in about an hour. Well, there actually might be more or less than 18 questions, and some of them might not be easy, but got you here. So for most of these questions, I will provide some background information. Then a question will appear on your screen. You'll have 15 to 20 seconds to vote on an answer, which will all be able to see the total. Responses are anonymous. Do not overthink. Partly we don't have time. And sometimes the group will be in full agreement on an answer. Sometimes the group may be split. Both possibilities are real and useful to know. Where time allows, we might take a few minutes to discuss differences. Please help to keep our discussions efficient. And now I'm going to begin screen share here. And I'm working with both my right and left hand, so I should at least get some credit for that. Okay.
Bipartisan.
We're going to start with just a simple question to check the technology. Call it question 0. And the question is, can humans solve problems? Your choices are: yes, we are bright, adaptable to act in our common interests, or unsure, we need to form a committee to ponder that. So, Mike, can you launch question 0? Wow, a lot of confidence here.
Where's the answer? I mean, well, where are the results?
Mike, can you do you have a button to share the results? I see them, but maybe it's because I'm co-host.
Wow. Okay. 88%.
Yeah. Okay. Now we'll stop sharing. Mike, if you could stop the share and close the poll window. Okay. So, healthcare in America has been gradually eating our lunch, so to speak, for over 70 years. We are getting some more for our money, but it's really taken greater and greater percentage of our collective incomes. Every new dollar spent on healthcare is a dollar which used to provide us with something else that we thought was important. There was a time when the cost of healthcare in the United States was about the same as other countries. But now it is about double. These numbers are actually a few years old, so It's more like 12,000 and 6,000 or more. One of our societal responses to the increase in cost has been to underpay providers for services provided by Medicare and Medicaid. According to actuarial data from the Oregon Task Force on Universal Health Care, Medicaid now pays just 69 cents on the average cost of providing a dollar of care. Medicare pays 81 cents. Private insurance has gradually risen to $1.37, make up the difference for declining Medicare and Medicaid reimbursements. There is an old axiom that the easiest and surest way to accomplish nothing is set about to do everything. So I'm going to allow everybody to take a look at this list. We have a choice of getting the costs down more like other countries, spending more on behavioral, primary, and regional care, spreading the cost of the sick onto the healthy, improving equitable access for minority Medicare, Medicaid, and separating healthcare from employment, distributing the cost more progressively, whatever that means, and ending high anxiety and the stress of complexity, or choose something else. So Mike, could you launch question 1A?
So Warren, is the question, what do we think we should be doing? Or what's our?
Yes,
Okay.
yes.
Oh, it should be, okay.
Well, yes, and I really am making it kind of in lines with what do you think the governance board should be? But it's our collective advocate movement.
So we're supposed to indicate which one? Only
Yes.
one,
Only one,
only one.
your first choice, the one that's most important.
Okay,
Okay, it looks like we have a darn near even spread across all of them.
oh,
Mike, Mike, can you share the results?
Yeah, it should be.
It is.
Okay. All right, very good.
it should be
Now-
what?
Yeah.
What should it be?
Yeah, it's showing.
It's visible. I
It's
think
visible.
everybody can see the results. Now, going to actually ask everyone, going to close this poll and open question 1B, which is, what is your second choice?
Oh, gosh. Hmm. Hmm. Hmm.
Okay, we'll close this one and we'll give everybody a chance for their to enter their third choice. Mike, if you could enter question or launch question 1C.
So you want me to show the results of this question 1B?
Oh, let's just go ahead and go get to 1C.
Okay. Question 1C, launching.
Okay, and can you share that, Mike?
Okay. So share results. It seems to take about 5 seconds for it to come up.
Wouldn't we want to see 1B before we see 1C?
Might be too late. I might have fouled that up, unless Mike
What-
can go back.
I can go back, I think.
Can you put all three up there?
Let's see if we can.
I don't think so.
You're right. Once we've gone by it, I don't think we can show it. Okay.
And what I get out of what I can see here is that there's some maybe trends, but actually there's a lot of priorities, and of course that's a challenge to us for advocates. Some of these actually are very compatible. Some of them are darn near mutually exclusive. Are we going to try to spend more money? Yeah, we can do a lot of things with extra money, but we don't necessarily want to try for 3 or 4 times as much spending on healthcare as other countries. So, Mike, if you could make this go away.
Okay. Uh,
I
Is
might
it-
be able to.
it takes about 5
I-
seconds, I think.
Okay. So moving on here. On here. So in 2019, the Elway poll actually turned up three top voter issues: high and rising cost, complexity of billing networks, pre-authorizations, issues of equitable access.
Are you sharing right now, Warren? Are you sharing your
yes.
screen?
Can everybody see my screen?
I can.
Oh,
I can see your screen, but I also see the poll.
I can
Close the poll.
Yeah, you
Oh,
can
yes, I
close-
closed it.
Yeah,
Yeah.
you can close it yourself.
Right.
Yeah. If the poll is in your way, you can close it.
okay.
The Oregon task force that made its final report in 2022 actually selected these same 3 items for its problem statements: high and rising costs, complexity of building networks, pre-authorizations, and issues of equitable access. We keep adding to a list of problems: shortage of providers, long wait times, pending decrease in federal support, mergers and acquisitions limit local sense of ownership, seeming explosion of behavioral health needs, economic challenges of the state are actually losing employers. We passed Measure 111, funded an obligation of the state to ensure healthcare, but we didn't do anything to fund that. So all of these things are hanging over our heads. I won't ask you to prioritize these, but just keep them in mind as we launch into our work. So here is question 2. Who will ultimately approve, if we come up with a plan, who will ultimately approve a universal healthcare plan? You've got 3 choices: Oregon governor, Oregon legislature, or Oregon voters. So, Mike, if you could launch question 2.
okay. Question 2. Let's see if it's,
Is this a test or a question?
Uh-huh.
In other words, who should or who actually is already on the hook?
In actuality, this is a question a little bit of who do we ultimately need to be considering that's going to approve this? Or that it will not come about. So Mike, have you launched the question yet?
It's didn't let me. I'll try it again. Oh, here we go, maybe. No, it's not letting me. Who will ultimately approve the plan? Let's save. I'll go back. Question 2. Has disappeared. Oh, here it is. Okay, question 2. It won't let me launch it. We'll have to do a hand vote. The governor, legislature, voters.
How do we answer it?
I was going to abstain anyway.
Yes. I'm going to let's see here. So will it not let you launch any questions, Mike?
Let's see. We'll go to the next one and see what happens. Next one would be question 3. It's
Yeah,
not.
I'm trying to figure out whether we've got a total collapse or okay, I'm going to do a stop share.
Okay.
And then I'm going to,
Did we already show this one?
Yep.
Okay, so stop sharing.
yeah, I can do a launch now. I just launched it.
Great.
So you were able to launch question 2.
Yeah.
I don't see it yet.
I do.
Do
We've got the
others?
poll up. The
Yeah.
poll for question 2.
I answered it.
Yeah, I think we got, and I'll share the results with you.
All right.
Not surprising. And now I'll go back. And did it disappear for everyone?
Yeah,
Okay. Oh. Yeah, it's switching back and forth. It will not be easy. Okay. He's back to full screen here. So we got that one. Now, the 2019 Elway poll of Oregon voters showed that 62% of voters were interested in a large tax to provide health care for everyone with no premiums, copays, or deductibles. But more needs to be considered about that voter support. When it's broken down into strengths of support, about 20%, actually 21% of respondents expressed definite support or definite opposition. And that's Stuart Elway, the pollster, says that's typical of public where 20% of the population on both ends is unmovable without any discussion of actual details. The remaining voters are open to further discussion. When I mentioned that Oregon in 2002 and Colorado in 2016 went down by an identical 21-79 margin, he pointed out that we really haven't made much impact on the middle ground of people who are looking for more information. So here is a question. How will Mike, you can begin loading question 3. How will voters decide? Rock, paper, scissors, political party, ideological confidence, or the financial soundness of plan, and how the plan will benefit individuals, providers, and businesses?
So I just launched it. It may take, oh,
Yeah.
somebody's already answering.
Yep. Yeah, this is interesting. So, have you shared that, Mike?
Let's see, end poll and share.
So this is very close, and it's quite a clue to some differences that we see in the advocate community. Fortunately, no one chose rock, paper, scissors. So now let's go back here, and if you can close that out, Mike.
Okay. I just closed it.
Okay, I think I have to close my window. SB 1089, which created the Universal Care Governance Board, specified that the governance board design the financial plan based on a single payer system. But what is a single payer system? I know of about 16 states working on a quote single payer system, and no two are alike. Oh, what the heck is a single payer system? What does it do? Here is a chart of major healthcare financial flows constructed for Oregon. For now, all you need to know is the state residents are on the left, healthcare providers are on the right. Payments flow from state residents to healthcare providers. Everything in between is governmental or is a governmental or private middleman. A common misunderstanding is that the single payer system saves money by eliminating insurance company profit. A basic takeaway of Oregon's task force actuarial study found that the major savings from a single payer system is not from eliminating the insurance, is actually from eliminating the insurance payment complexity. Governmentalization does not save money unless it is used effectively to achieve simplification. Simplification is what saves money. So here is another version of the flow chart, but with areas of financial inefficiency shown in red, as described by the actuarial work for the 2022 task force. The total billing inefficiency is about 25%. Most of that inefficiency is in provider billing offices, having to jump through hoops to get paid. The next most is in private insurance companies, which handle about 1/3 of all payments. Here's what a single payer system could look like with inefficiency reduced by about 16%, from about 25% down to about 9%. Perhaps even more welcome is the virtual elimination of payment complexity, because a single payer system would not pay a different amount based on who the patient is. Major source of inequity could be eliminated. Single payer system can also help with provider shortage by letting them spend more of their day with patients. There's a whole list of things that a single payer system cannot do, but it's good at what it does, which is simplification. In a true single payer system, there's only one way for providers who see public patients to be paid. Any system that has more than one way for providers to get paid is actually not a single payer system. Anyone who wants to bring down the costs similar to other countries needs to ask the question, why does healthcare cost more in the United States? Where is that extra money going? There are two peer-reviewed studies that have addressed this question, one by Dr. Irene Papanikolaou of London School of Economics, one by Commonwealth Fund. Both came to the same conclusion. The US gets about the same amount of actual medical care, but it pays more for care in three approximately equal ways. Higher costs for the same drugs, higher healthcare labor costs in the United States, higher cost of financial billing administration. Any plan to reduce healthcare costs in the US needs to address one or more of these three specific costs. If it is based on some other theory of saving money, probably won't save much. Single payer system directly addresses higher financial administration cost. It really doesn't do anything to address higher labor costs or higher drug costs unless something separately is done for those. So, can a single payer system can a partial single payer system save money? The answer to that question isn't clear at all. Might depend on what is left out. Academic studies showing large savings are all based on full single payer systems. We don't actually know what would happen with a partial system, but some studies, including by Colorado School of Public Health, propose that the efficiency advantages of the single payer system don't actually kick in until virtually everyone is in the single payer system. To illustrate this problem, consider a hospital that bills 100 different payment plans. If half of the participants in each payment plan are converted to a quote single payer plan, hospital still needs to maintain billing expertise and software for all 100 plans. It isn't until the hospital billing department is completely eliminated as unnecessary that the real savings are realized. Once there is no billing and haggling like anything that we think of today. So question 4, should Oregon design a true single payer system for covered services that can eliminate all provider billing as we know it today? You can answer yes, that's the whole point, or no, we need to keep the regular multi-payer capability system intact and build on that. So, Mike.
I have a quick question.
Yes?
How would that affect jobs? Like, I could foresee an issue coming up where people would be concerned for like a large amount of people losing their jobs if billing departments were eliminated. What would be your response to that?
That is a part that we won't get into today, but it is part of the design to actually potentially use some of the savings to pay for retraining for people to move into different jobs. And because of the added need for healthcare, there should be more jobs in healthcare.
Okay, thank you.
Mike, have you shared that result?
Ah, very good.
Yeah, we actually scored big here. Okay, so if we can close that out, Mike. Or I can close out. So now we can get started with plan design. If you look back at the previous flowchart of a single payer system, there are two early decisions for setting up a single payer system. First, in the upper right-hand corner of this single-payer flowchart, box of direct care programs, which are not like the others. We'll talk just a moment about what makes these different and whether we should include them in a single-payer system. Some programs would be hard to integrate into a single-payer system. Examples are Veterans Administration, particularly a state-run system, the Veterans Administration, military facilities, Indian Health Services, student care in schools, employer-provided clinics such as in remote areas or research vessels, university infirmaries funded by fees, student fees, prisons, and similar publicly operated institution. The attributes of those programs is they have a special purpose. They have their own separate funding sources. They provide care directly to their limited constituency. They are not open to the public. That doesn't mean a single payer system couldn't provide extra services to these groups, just that a single payer system will not take over or should not take over the administration or funding of these programs. So question 5, should we allow these programs, as mentioned below, to continue to operate separately from a state single payer system? So Mike, if you could launch.
Mm. Yeah. Mm.
Okay, let's end the poll. Interesting result. If I could just take time for someone to offer the opinion of why those other programs should be dismantled immediately.
Because they have universal care. It's simple.
Okay.
Efficiencies of a single market.
Bobby?
Because the feds are already starting to pull money back on these already. So to me, although I might have said yes last year, this year, I think this is the time to pull them in.
Okay, and I'll say that one of the reasons why other groups have decided not to pull them in is continuity of service. If you've had however many years with the VA, steadily closing the VA is probably not what we want for those patients. But this is obviously a very legitimate question. Okay, Mike, if you could close that out.
Yeah, I'm wondering whether you would close out some, but not all of them.
And that could be.
Yeah.
Yeah, and along those lines, it seems like, a gradual switch over. I mean, usually it's better to go gradually than, if you can, than do anything all at once, seems like.
Yeah. Okay, those are good points. So now we'll use the assumption that have not included those, but now we still have to include Medicare, Medicaid. We have to get all of these things merged into the single payer system. All other private coverage, including employer coverage, union coverage, retirement medical from previous employers, individually purchased coverage, Medigap, supplemental, our out-of-pockets for covered services, and medical portion of liability insurance, including workers' comp, home, auto, business, malpractice. We have to be able to collect the money from trusts that are providing care for people. and we need to figure out some way to fund the coverage for out-of-state visitors. We're going to jump into the financing because that's where it gets really interesting, but I'll just propose some basic assumptions. All Oregon residents are eligible regardless of income or employment. We will include visitors who need immediate care or emergency stabilization to get them back home. Providers, all Oregon providers who deal with the public must follow the rules and rates annually by payer entity. Providers may not bill any patient or insurer for covered services. Providers may not accept other or additional payment for treating patients. Some of these deserve more discussion, but we're going to save that for a little later if we have time. So first, jumping into the public discussion here. How do we currently pay for healthcare? We pay and we've got the major payers, or all payers, private health insurance, including the liability insurers, Medicare, Medicaid, out-of-pocket donations, workers' compensation. But insurance companies, governments have never paid $1 for healthcare. Let me repeat that. Insurance companies, governments have never paid $1 for healthcare. They are middlemen using the money that we send to them, or give to them, they receive from us. So now, looking at this differently, Medicare is a good example where funded through several means, mostly. Actually, the largest source is almost 50% is coming from federal general taxes. The payroll taxes only cover 36% of the cost of Medicare, and Part B and D premiums only cover 15%. Medicaid, on the other hand, is not complicated. It's completely funded by, almost completely funded by general revenues, general fund taxation at the federal and state level. So if we make those adjustments, we find out that who really pays for healthcare, of course, is us, from our about 43% from our private insurance premiums and cost sharing, from about 35% up to 37% from our general fund taxes, and from our Medicare taxes on payroll, self-employment, it's payroll and self-employment, from our cash payments, from our donations, other third-party revenues, and from our Medicare premiums. So how do we go about collecting all this revenue into a single payer system? We will allow a series of funding principles to help guide us. Know that many of you are chomping at the bit to find out how much of the 16% potential savings you will get. But first, we have to figure out how to build the new system based on incorporating all current sources of revenue. Good news, as most everyone here knows, that in total, we already pay enough. We don't need to raise new taxes as long as we can redirect everything we pay now. Once we've built on the new system, based on incorporating all current sources of revenue, then we can talk about how the savings. Till then, don't want anybody asking, are we there yet? Are we there yet? Have we got to the savings part yet? We're not there yet. Something that isn't widely known is that Oregon's current uninsured consists mostly of people who are eligible for coverage, but haven't signed up for it. Some are healthy people qualify for Medicaid but haven't signed up. Some are healthy people who are trying to sneak by without any insurance. Some are people who just don't like insurance. Cost of including these people in the system is about a break even. Some will add cost to the system. Others who are avoiding paying to the system will be required to do so and make up some of the difference. Nobody gets to opt out. So now we'll go to question 6. Do you agree with the principle of everybody in and nobody may opt out? Okay, we'll end that poll. Seem to have pretty much unanimous agreement.
Now, this doesn't mean that you theoretically could pay a patient could just himself or herself pay directly the doctor rather than have any insurance involvement, right?
Yes, and there is a case for that. And it'd be nice if we have a little more time to talk about that later. But that's a question of which benefits you choose. You're not going to pay cash. Well, obviously, I'm not going to pay cash for $250,000 surgery, but I might prefer to take cash to my primary care provider. Is a realistic question. So, funding principle B is that there's no windfall or free ride. Nobody hits the jackpot in the switch to universal care. Every existing payer should expect that they will continue to pay, perhaps in the same way, perhaps in just a similar way, but they'll each be raising about the same amount of money. That's at least until we get to the part where we divvy up the savings. So going back to that list of everybody that we need to merge into the single payer system, we've got some different ways to do that. For Medicare and Medicaid, we will continue the current taxes that support those programs, and then we'll need a federal waiver to merge those into an Oregon plan. For employer coverage, we'll use a payroll tax. Employer or union for existing employees will use a payroll tax. For the employee portion of employee coverage or individuals purchasing their own coverage and Medicare supplemental and out of pocket, we'll use a healthcare tax on income. For the medical part of liability insurance, we can devise an insurance assessment, and we may need to divide some other assessment to be sure that we're collecting money from the trusts and from previous employers who have set up trusts. One of the big questions in Oregon, and the governance board is wrestling with it now, is how do you handle the cost of out-of-state visitors? We've considered sales tax or a lodging tax. It's not completely inconceivable that this would be a case where we would just not charge them anything because it might be harder to raise the funds. But that, of course, that raises the cost for everyone else a little bit. So now, question 7. Do you agree with the principle of no windfall, that everybody is still going to have to pay into the system who currently pays into the system? Okay. Yeah, I want later to find out the answer no, just what that means, but we're going to be pressed for time here. So maybe we can hold that till open questions. So Mike, if you can make this go away. And I will proceed. So funding principle C, people shouldn't have to pay more based on health status. This current system charges the sick and injured extra for their medical care, but the new system will not. This means that average people will have to pay more to some degree. This graph tells you almost everything there is to know about medical care and insurance. In any given year, most people don't use much care, but a few people need a lot. Most expensive few patients will be in the millions of dollars. Insurance has saved tens of millions of lives by socializing the risk. That is, spreading the risk of high cost, low probability health events across a wide population. For most people, once their out-of-pocket reaches their deductible limit, their risk of higher costs goes away. Although we have eliminated most of the risk of being sick or injured, we currently do have some charges that the sick and injured people must pay more in co-pays, co-insurance, deductibles than they would have to pay if they were not sick or injured. So this means that completely eliminate the charges to the sick and injured. Everyone else must pay more. Perhaps 80% of the people pay 200 to 500 more a year in order for healthy people to not have to pay any extra. The good news is that even though people will have to pay more, there will be no stress out about maybe having a bad year next year and having to pay extra. This really isn't a planned decision. In a new style of billing system, we probably won't be able to keep track of costs on individual patient basis. How will we know who to charge if we haven't been keeping track, having a scorekeeper keeping track of who's using every dollar? Another way that sicker people currently pay more is through separate risk pools. When it takes the premiums of about 500 healthy people to pay the cost of one patient in the top 1%, shows why insurance companies want to attract healthy people and discourage sicker ones. And we're no different. We each want to be in the pool with healthier people. The three arrows on this graph are placed on the chart schematically to represent three different insurance plans. Plan A is only for employer-provided Medicare or medical care, and the health expenditures and premiums are lower because chronically sick people don't have jobs, or at least not the kind that provide health care. The other hand, Plan C is only for sale to individuals. It will include higher percentage of sicker people, and the expenses and premiums will be higher. Nobody wants to be in that group, but they don't have a choice. Insurance companies spend a lot of money and effort trying to keep a healthy pool and discouraging sicker ones. Under a single payer, single pool system, we save money by stopping the stupid game of gaming the risk, and we will end up at B, sort of an average. This is a fundamental attribute of a single payer plan. There is only one risk pool, which is all of us. There is another way that people might be charged more. That is, if they're smokers, obese, bad habits, bad genetics. Universal care systems around the world almost never charge for this. It is just too hard to keep track or to figure out where to draw a line. Universal care is about compassion, after all. So question 8, do you agree with the principle that no one should pay a different amount because of their health status or their risk pool? Okay, Mike, if you could close that out. We'll get on to Principle D. Historically, young adults have paid less for insurance because of age rating. This is important for people just starting out. If all remaining age rating is suddenly removed, the burden for some young adults will double or triple, harming their ability to strive. Medicare transferred the higher costs of care from older people onto younger people in 1965 through payroll taxes during the working years. Later, the ACA further transferred a little more of the cost onto young people by limiting age-rated premiums from a factor of 6 to a factor of 3. But if universal care is implemented without any remaining age rating, the cost for some young adults and young families could see their costs tripling by $6,000 to $8,000 per year. Speaking for myself, if I had had to pay for that when I was young, I would probably never have owned a house, never been able to start saving for retirement. There's question 9. Do you agree with the principle of protecting young adults from sudden doubling or tripling of their historical cost burden? Question 9, Mike. Okay. We'll close that out. Thank you. So funding principle E, no one should have to pay a new tax for benefits they already receive at no cost. If they are to be charged additionally, it should be aligned with an increase in benefits. This applies to people on Medicare, Medicaid, Veterans Administration, and Indian Health Services. Question 10, do you agree with this principle protecting Medicare, Medicaid, VA, IHS recipients from paying more, except for the value of new services that they get? Mike, you are on question 11. Can we back out of this one and do question 10?
I'll see if I can. There we go.
Okay. And let's close that out. So principle F, people with same incomes should contribute equally to the single payer system, regardless of income source. Funding equity must be maintained between individuals, whether employed, self-employed, or receiving income from other sources such as rents, royalties, or investments. Probably the most well-known tax for social benefits is FICA tax, mostly funding Social Security and some Medicare. 15.3% tax on all, quote, earned income from work. This chart shows three individuals, each with an AGI of $60,000. One is an employee, one is self-employed, the other gets income solely from rents, royalties, etc. None of which are counted as income from work. Only two of the individuals are eligible for Social Security, and they both owe 60,000 times 15.3%, or $9,180 in contributions to the social program. The other individual owes no FICA tax. Their income, along with income above the Social Security cap, does not qualify for calculating eligibility and does not qualify for benefits. The employee and the self-employed person are treated equitably under this 90-year-old system because they both pay the same total amount into the system. Sometimes we hear it expressed that there is an employer part and an employee part, and that self-employed individuals pay both parts. It would be just as correct and perhaps simpler to say that we are charging both individuals the full amount, but we give the employee credit for the half which was already paid by the employer. Moving on to fairness in healthcare taxation could work similarly. Looking at healthcare contributions, only the employee receives a policy through their employer, while the other two individuals who currently buy their own healthcare policies. The employee still does pay a portion of the premium cost as well as some out-of-pocket costs. The goal, of course, is for all three to pay the same amount in total to the single payer system. To keep equity between the three individuals, the employee is credited with the amount paid by the employer, just like FICA has been doing for 90 years as a standard of equity. Now I'm moving on to question 11, and I don't know if you can relaunch this, Mike.
Okay.
Do you agree with the principle that people with the same incomes should contribute equally regardless of their income source?
Yeah.
And you've got three choices. Okay. Thank you, Mike. Make that disappear, and we'll move on. Let's see here. Funding principle G, for covered services, the new system should expect equity between employers. Current system expects some employers to contribute, but allows others to be subsidized, or other whole industries to be subsidized at cost to the public. And the public funding should expect all to pay under the same rules. Of course, some will pay less because wages are less and profits in some areas, but we can and should expect that everyone is paying the same proportion unless some specific exemption is granted. So, question 12, do you agree with this principle expecting equity to be established between employer groups? Okay, if you can make this go away. Thank you. Now, we're going to get back to kind of a little more of an open question. when I first started hanging around universal care advocates, I couldn't really tell whether their purpose was to concentrate on reducing costs to a level more like other countries or concentrate on transferring the high cost onto others. Everything that we've done so far in reform in the United States has been to transfer the cost onto younger, healthier, higher income people. Single payer is unique in that it can reduce costs through efficiency. It isn't necessarily true that we have to transfer costs, but we can in a single payer system. Here's a graph depicting what the task force did. It's concentrated almost nothing at all on saving money, and but interested in about 16 billion change in who pays. So funding principle H, the cost of care should be distributed according to a progressive distribution. And this is actually spelled out in SB 1089. So it is seemingly a requirement for Oregon, but it doesn't really explain what that means. So what is a progressive distribution? Most anything where people can pay a higher, where as income goes up, the percentage of income goes up. So here is an example. Here's an example of one which the governance board is considering right now. And some people have complained that this is not progressive, but yes, it actually is an example of a progressive distribution. And here's the evidence of that, showing how the rate per income is a percentage of tax against income is actually climbing as income goes up. Oregon taxpayers, now it's really a question of does Oregon already have a progressive distribution of how we fund healthcare? Here is a graph showing that fifth quintile currently paying over half of all healthcare costs, principally through their existing federal and state taxes, which fund nearly all of Medicaid, half of Medicare. Reasonable question to ask whether the distribution is already progressive, as those with higher incomes are paying for people on Medicaid and half of people on Medicare. But taking a closer look, this was actually not quite a progressive distribution. Here we've got two colors going. Note the difference in the blue income distribution column, orange healthcare cost distribution. The fifth quintile is carrying a lot of the cost of healthcare burden, but is still a little short compared with its share of the income. So Mike Huntington will like this. He's always wanted to see a graph of pain, a pain index. So if we describe pain as what percentage of your income is actually being borne by paying for healthcare, we see that the most disadvantaged are the second and third quintiles, and that the fifth quintile, even though it pays quite a lot, is still short of its share. So putting it another way, this doesn't include some other necessary adjustments, but this is what could need to happen to adjust the pain equally, that people in the second quintile could have their cost cut by about half, and people in the fifth quintile, we're not looking at it like 100 doubling their contribution, but a 25% increase would actually bring them up to equalizing the pain. So Here is question number 14. Should the cost of healthcare be distributed in a more progressive manner? The choices are the bigger the shift toward higher earners, the better. B, a moderate shift toward higher earners, okay, as long as it doesn't place an undue burden on health providers or drive significant opposition to the plan. C is there should be no shift toward higher earners. So, Mike, if you okay? It looks to me like the moderates are slower at getting to the button. Maybe there's a correlation there. Don't know. So anyway, that's interesting. So Mike, if we could get rid of that. And funding principle I is to avoid shock treatment, to try to keep decreases and increases within some kind of reasonable range. This can be both for the individuals as far as people either setting to pay many thousands of dollars less or $100,000 more at the high range, that there is an idea of keeping the decreases and increases within the reasonable range, avoids shock treatment. Here is a graph of how long it took to implement Social Security. It took 50 years to gradually get people from other programs and putting this money into Social Security and Medicare. It would be quite a shift to try to implement this in the course of one day from December 31st to January 1st would be leave us open to certainly to some fears of change. So question 15 is do bigger changes to individuals and society as a whole, will they result in bigger opposition at the ballot box? And Mike, question 15.
I'm seeing a grayed out launch here, so I'm not sure why.
Okay, well, we won't worry about that for just a second. It's a little bit of a rhetorical question without an absolute answer. So we will move on. The principle J, funding must be sustainable. Once healthcare is publicly financed, healthcare expenditures cannot rise more than public finances rise. And that, as we see the red line here coming up in healthcare, that means to be sustainable. And we've actually got to stop the rise. I mean, that is a question. Is the intent to stop the rise and to do what we need to do, make sacrifices or decisions to do that? So question 16, do you support the principle that funding must be sustainable to public finances? So can you get that one, Mike?
No, it is also grayed out.
Have you got one open somewhere?
Oh, let's see. They're all ended.
14 is still open.
Okay. Stop sharing. Now let's see, we want 16. Looks like it's open.
Thank you. Voice from the gallery. Okay, so we will stop this and close this out.
Okay.
And now we're there. Now that we've stepped through all of these things, we have a question, which is who gets the savings? We get to make the decision now to spread it out evenly, spread it out among the sick and the injured, use the savings to pay for more care, give the savings to the second and third quintiles, distribute the savings to employers or unions. And these are not just kind of open to conjecture. The task force decided to make lower payroll rates to induce employers to voluntarily participate. And also, I've seen union paperwork that says that they want a chance to negotiate for any savings that occur from the system. So after that, we could give the income, the savings for higher incomes to health providers, ensure nearby care everywhere in the state, use the savings to replace loss of federal funds, use the savings to get the new system started on stable footing. And for fun of it, Mike, if you could load question 17, and we'll give people a moment to see if we've got what we think. There might really be some more votes coming in, but it looks for the moment like the winner is use the savings to get the new system started on stable financial footing. So that is where we will stop, and I appreciate everybody's participation, and I hope it's been I've got some insight into how people think about things, and I hope we've all got a little insight into what the governance board is facing and how we might answer some of the same pressing questions. So I will turn it over to you, Mark. I know you've got some other things that you would like to do. I'll be around and we'll take more questions, but also respect that this is a regular meeting. So anyway, thanks everybody.
Well,
it's been kind
Thank
of
you, Warren. That was terrific.
Thank you,
And,
Warren.
yeah, let's quickly run through, and then we can see if people have questions or comments for Warren. But are there any of the committee chairs who feel a need to give a report?
I can go ahead and give a quick one.
Fritz, yes.
That's right. So communications and outreach, we have been, ever since I came on board a little over 3 years ago, one of our drives has been to really try and decrease the average age of our members. And quite frankly, this last year, we have really been kind of making a lot of good strides in that area. I think I saw, yep, I see Amanda still on. Amanda Labonte, who is kind of the facilitator of our Student Community Council, which is made up of mostly OSU students. They were pretty active this last year. This year, we've actually made some connections with the Western Medical School, the OD school in Lebanon. And I did see earlier that there were a couple of the med students from there that were on the call. And we're continuing to do those types of things. Mike and I and Simon actually had a meeting, not last week, the week before, actually, with a couple of the graduate student stewards on the OSU campus, of which I think the number is about 700 of them. So they're the unionized graduate assistants who do all sorts of work for professors on campus. So we've made a real good contact with them, and that's going to help us grow our numbers, which is really cool. So some of that work that we've been doing, I think, is going up, and I even see one of them on, Matthew Vanini's on. So Matt, glad to see you're on this call. It's just been real positive. One of the things that we kind of abandoned, well, we did abandon this summer, is the tabling at the farmers market. Matt's waving to us, cool. Some of it had to do with the fact that we've got all sorts of other opportunities now, given the current environment in our country for tabling at rather large events. And those rather large events have been, from a membership growth, significantly better than the time we've been spending at the farmers market. It's been quite good. And actually, this last large event a couple of weekends ago, we actually divided forces. We tabled in two different locations. We had a table out in front of the Benton County courthouse. And then we also had a table in Lebanon, which I tabled with, actually, as I mentioned, a lot of the DO students. We've got 7 of them currently that came and helped us canvass the crowd and get signatures and get more people educated and involved in this process. So I'll kind of stop. I went a little long-winded, but again, I'm really excited at the fact that we've got people that are very interested in this, and they're very interested in being a part of our organization. So it's really cool. Thank you.
Yeah, I'll just say, tabling at the in front of the courthouse, some young people just walked up and said, "Sign me up." They didn't even have questions. They just want universal health care for the future of their lives. Many of us will live with whatever gets created for a short while. They are going to live with it, whatever gets created, for a very long while. Either of the other committees want to make a report? No? Okay. Any officers want to make a report briefly? Nope. I'll just say that we have 4 members of our legislative committee are going to do a presentation on Wednesday at 1:30 at what we used to call the Senior Center and is now called the Corvallis Community Center at the park there, and would encourage people to attend. And there is a Zoom link that I sent out to a bunch of folks, but could send to others. And maybe now we'll go to, are there any pressing questions or comments for Warren in regard to his presentation?
Warren, yeah, I do. Obviously this was kind of a dry run, right? And do you have any other groups kind of lined up yet that you're planning on running through this with? Because I think it's not only educational, but 2, it's an opportunity for you to collect some data.
Yeah, there is nothing planned. It's just kind of a new experiment, and the fundamental reason for doing it is that I think informed advocates who've really thought through some of the issues, including some of the harder issues, are going to be helpful. At the last governance board meeting, for instance, there was public testimony who said, we're for universal care because then our union won't have to pay for healthcare anymore, and we can use that money for something else. And that really is a very different viewpoint than I think than reality would show. But I think the more that we know, the better that we talk, the more sense we make, the further we get. Shelley?
Yeah, I wanted to say this was really thought-provoking, and there was some really nuanced presentation in there. And I think that it would be very helpful to give this to other people who are not quite sure how to present single payer ideas, and also not presenting some of the concepts that you were presenting. So I think it was, I got a lot out of it, and I'm already very opinionated about it.
Thank you, Shelley. Matthew.
Hey, Warren, thanks so much. This was, super cool presentation. I just wanted to say I thought it was really good. And I would recommend doing more of it. But I would just have like more space for other responses, because I think a lot of it there's a little bit of nuance, and like a lot of like ones that I would have answered have like an opportunity for a write-in. But I think it's super useful for presenting these and maybe learning more about what the people of Oregon are thinking about.
And that, as we're planning this, I thought, boy, it'd be nice to give somebody an ether and 300 characters to type. But we just can't handle that in this type. If we'd had more time, I would have particularly asked when there's a small minority of people who think, I want to know why. What are they seeing? That would be most interesting to me. Betsy?
Yeah, this was a great presentation, and it really struck me that these are the kinds of questions and the kinds of information that it would behoove the governance board to be looking at as they do outreach, which just the combination of presenting information and then asking for thoughtful feedback is the kind of thing that we would really hope would happen broadly. So thank you for showing us how it should be done. Check.
Thanks, Betsy. John?
Yeah, I thank you also, Warren. This was great. One of the questions that you asked, or was in all the questions, was this one about, should people that are on drugs, alcohol, pay more? And yes, I drink wine and I drink beer, but this is a health thing. And when you have things that are contributing against health, why just embrace those people? Why not give them some incentives by charging them more to get off of their habits that are going to cost all of the rest of us more money?
That's an interesting question. Chun-Wei Chi, associated with the Taiwan system, helped them design it, notes that something like 8 times the question has come up as to charging people extra for those things. And it's been turned down every time so far, just for the reasons of, including some kind of dangers. If certain kinds of addictions are actually entirely dependent on genetics, who are we to say someone is lesser, might have lesser access to care? So I don't know the answer, but I know the arguments, and I think that they should be, we should be made. Certainly the task force 2 years ago in our public outreaches heard a lot of people say, I don't want to pay for other people who don't take care of themselves. Personally, I've lost 5 friends to cancer. None of them deserved it. None of them, I mean, they were doing everything right. And I'm not going to be one who believes that we should be charging people differently by trying to figure out how much extra they cost. But I appreciate the argument, John. Mark.
Thank you.
Yeah, I'll just follow up what you were saying, Warren. What we seem to know about addiction is once somebody is addicted, they will pay any amount of money. They will even commit crimes if they need to get money to pay for it. The cost of cigarettes is what, 8 or 10 times what it was 20 years ago, and people are readily paying for it. And so it's a tricky issue. We would actually have to provide addiction therapy, the behavioral health end of things. And that would add a significant cost to the whole system, it seems to me. Any last question? We're kind of at time here.
I would like to go back to something that Betsy said, and that is, it's related to her comments. When you go back and look at one of the questions, there is a question about what will win the day at the ballot box. Is it sort of political party confidence, or is it a whole lot of details about who's going to pay more or less? And I noticed that question in our poll was split with strong answers on both sides. And that is really does pose some problems for advocates. And it poses a bigger problem for legislators, because they say, well, who's going to vote for this? Oh, we are. All of our friends. One of the things that came up out of the Elway poll. I'm just going to show you this little box. It's right here. In the Elway poll, Democrats counted for 30% of the electorate, Republicans 25%, other voters 40%. Democrats actually supported a large tax for universal care, 80% of them. But guess what? That only gets you 28% of the total vote. And no one is going to say that we should go out for a vote unless we've got 60% support. So the Democrats can't do it on their own. The other voters, mostly non-affiliated voters, even those together with the Democrats can't come in. We really need about 40% vote from Republicans. And that is going to be, I can tell you, that's going to be very difficult to get there if we frame this as a partisan issue.